We now are going to look at an important part of the practice of echocardiography, and that is stress echocardiography. In our own institution, it represents a high percentage of all of the tests that we do. We're starting off looking at a treadmill stress echocardiogram. Now, I should explain that our treadmill studies are done with one resting image in the upper left-hand corner and 3 post images. Since the post images or the immediate post images are the key to normalcy, and the fact is that recovery of function can occur, we like to look at more than one image to help make the diagnosis. So that's the only thing slightly different about what you're going to see here than it is done in other laboratories. In any case, here we have the resting and post images in the long axis view, the short axis view, the 4-chamber view, and the 2-chamber view. And we also have the electrocardiogram. Now, to help with the interpretation of regional wall motion, which is not the easiest thing to do, this particular program has what's called a regional wall analysis guide. If we stop this process on frame 1, which is end diastole, we can use this regional wall tool to outline the endocardium in diastole and all the walls if you want. And we can do this at rest, and we can do this in any one of these with exercise. And then when we hit go, play, we can immediately see that at rest, all the systolic frames exceed and move towards the cavity compared with where it started in green. But that's not the case with the post. You can see that the proximal septum is moving quite vigorously, whereas the more distal septum hardly moves at all. The posterior wall is continuing to move normally. By the way, I did use the word posterior rather than inferior lateral. That's a slightly difference of opinion by some places. We can do the same thing in the short axis view, and again, you can also do it with just the pointer if you wish, and you can see how at around 12 o'clock or 11 o'clock, the walls are moving quite well, but then with the exercise, the wall is not moving at all. And the same phenomenon can be seen in the 4-chamber view, where the distal septum is moving normally at rest, but hardly moves at all with stress. Not quite as obvious in the 2-chamber view, but you can look at the apex, and it clearly is not moving as well as it should, especially the apical portion of the inferior wall. Now, despite that, the electrocardiogram was normal. So, the instructions are to make an interpretation, and it's looking at the stress program, and we look at it here, it wants to know how we felt about these walls. So at rest, everything looked pretty good. So we just will say no resting wall motion abnormality. But there's obviously a distal LAD, the distal septum, which represents the distal LAD, was abnormal. And it's in the post, and we say post distal LAD was akinetic. Now, he asks you for one more thing, and that is a conclusion. And the conclusion is that there is ischemic wall motion abnormalities. And that completes the stress echo case. We submit that. And we see that the review has exactly the same. So my interpretation and the creator's interpretation were the same. And there's a little bit of instruction there. It will help to identify how we made the diagnosis. You look at it, and you can see the arrow points out the non-moving wall. They also use the regional wall tool, as I did, and showing the wall motion. That's in the long axis. There we point out the abnormal wall in the short axis. We show the same in the 4-chamber view and in the 2-chamber view. And in addition, we give the angiographic confirmation, which shows a high-grade lesion in the left anterior descending coronary artery just past the first septal perforator, confirming our diagnosis despite the normal electrocardiogram. Now, obviously, we can also look at these data as a group and analyze these findings just as we did with the measurements and with the routine interpretations.